Welcome back, clinical documentation auditors and medical coders. I am so thrilled to have you here for part 3 of our Training Explainer series, where we take those dense, incredibly complex neurosurgical operative reports and translate them into precise, accurate codes. Today, we're diving straight into supratentorial brain tumor CPT coding. If you've ever felt completely overwhelmed by the sheer volume of anatomical terminology in a surgeon's note, well, you're in the exact right place.
Think about how you use a GPS. If you just type in the name of a city, sure, you'll end up generally in the right area, but you're still going to be completely lost when it comes to finding the exact house. It's the exact same thing in our profession. Just knowing a brain surgery took place, yeah, that simply isn't enough. Every single anatomical detail, every specific surgical technique, that is your exact address for code selection. Precision matters immensely here because even a minor misunderstanding of the surgical location can lead to a massive coding error.
So as investigators of the clinical record, we really have to ask ourselves, why do these specific anatomical boundaries and surgical approaches fundamentally alter the primary code we choose? Why does the specific anatomical room the surgeon works in and the surgical door they use to get inside dictate literally everything about your neurosurgery CPT code? Well, here's our roadmap for today's explainer. First, we'll map out the supratentorial anatomical landscape. Then, we'll use a 2-4 house analogy to make it stick. After that, we're breaking down CPT 61510 for general tumor removal and comparing it to CPT 61512 for supratentorial meningiomas. Finally, we'll wrap up with a definitive documentation and coding checklist. Okay, let's jump right into Section 1, the supratentorial anatomical landscape. We need to lay down the absolute fundamental anatomical boundaries of the brain because honestly, this is step 1 for any accurate chart review. So the human brain is physically divided by this absolutely crucial fibrous structure called the tentorium cerebelli. You can kind of think of this as the ceiling of the lower brain and the floor of the upper brain. Any surgery taking place above this definitive line is categorized as supratentorial. Establishing whether your surgeon is operating above or below this tentorium, that is the very first fork in the road for your coding logic. This upper region, the supratentorial space, contains the cerebrum. Now, when you're reading through an operative report, you're hunting for specific keywords that confirm you're actually in this territory. We're talking about the frontal, parietal, temporal, and occipital lobes. You also want to look out for deep structural terms like the corpus callosum, the basal ganglia, and the lateral ventricles. If your surgeon is working on any of those structures, you are solidly in the supratentorial zone. Moving on to Section 2, the 2-floor house analogy. To make translating these highly complex anatomical terms into alphanumeric codes completely intuitive, let's build a spatial framework together. I absolutely love this concept because it just makes everything click. All right, think of the human skull as a 2-floor house. That supratentorial region we just defined, that is the upstairs. It's where your living room, the bedrooms, and the kitchen are. Functionally, this upstairs area completely governs higher-level conscious functions, things like thinking, memory, and speech. Whenever a neurosurgeon is operating to preserve or repair these specific functions, they are working in the upstairs of our house. Now, when a surgeon enters this upstairs space, the clinical setup is highly specific, and it gives you a massive clue as an auditor. The patient is typically positioned supine, meaning they're lying face up on the operating table, and the surgical doorway or the initial incision is almost always made at the front or the top of the head. Contrast this entirely with the downstairs, the infratentorial region, where the patient is usually positioned face down, and the surgical entry is right at the back of the skull. Let's dive into Section 3. CPT 61510 for general tumor removal. Now that we're firmly upstairs in the supratentorial space, let's explore the primary code you're going to use for tumor excision in this specific room. The standard code for removing a primary tumor, like a glioma or an astrocytoma, or even a metastatic secondary tumor in this upper brain region, is 61510. The code description is crystal clear. It's for the excision of a supratentorial brain tumor, but notice it distinctly says except meningioma. We're going to get to that exception in just a second, but for most general tumors in the upper lobes, 61510 is your target code. Now, it is absolutely critical for billing compliance to remember exactly what is baked into this code. The creation of the initial burr holes, cutting and elevating the bone flap to actually perform the craniotomy, the meticulous opening of the dura to reach and resect the tumor, and finally replacing and securing that bone flap during closure, all of these steps are entirely bundled into this single code, 61510. You cannot under any circumstances unbundle these core surgical components. Which brings us to Section 4, CPT 61512 for supratentorial meningiomas. But what happens when the pathology report tells a completely different story about where the tissue actually originated? Well, this is where your attention to clinical detail really pays off. If the tumor originates specifically from the meninges, which is that protective dural lining covering the brain, rather than the brain tissue itself, the clinical scenario and the coding rules shift entirely. We are definitely still working in the upstairs of our house, but we're dealing with a totally different type of structural issue. Once you establish that you're in the upstairs compartment, histology becomes your ultimate tiebreaker. Non-meningiomas, those tumors growing within the actual brain tissue, are assigned to 61510. However, if the pathology report explicitly proves the tumor is a meningioma, it must be exclusively coded to 61512. The specific cellular makeup of the tumor literally dictates this precise shift in your code selection. Let's wrap things up with Section 5, the documentation and coding checklist. How do we take all this clinical logic and turn it into actionable steps for your daily chart reviews? Well, as an auditor, your truth lies entirely within the operative report. Never forget this guiding principle. The operative report tells exactly what the surgeon did, and this is the single most important document for selecting the correct CPT codes. You are essentially a detective, right? You're looking for the exact narrative of the main procedure to anchor your primary CPT code. So here is your definitive checklist to keep handy at your desk. Number 1, always verify the exact upstairs lobe or structure to confirm supratentorial placement. 2, confirm an open craniotomy technique was used, not a minimally invasive endoscopic approach. 3, check that final pathology report to definitively tiebreak between a meningioma and a non-meningioma. 4, ensure you aren't separately billing for bundled surgical approaches like the burr holes or the bone flap. And 5, keep a really sharp eye out for legitimate unbundled extras, like modern navigation guidance or complex graft reconstructions, which absolutely might warrant additional codes. By mastering this upstairs anatomy and using the pathology report as your ultimate guide, you are going to navigate these incredibly complex operative reports with total confidence and accuracy. The next time you see a brain tumor case land on your desk, just ask yourself, are they working in the upstairs living room or the downstairs basement? Keep practicing, keep analyzing those narratives, and continue to decode healthcare with Harshal.